Oh my God, we did not record it. Oh my God. Nobody. Okay. I don't know which part of we recorded and which part we didn't record it. I will just try to repeat some of the things because unfortunately I missed it, I think. We are discussing a topic of amputation. Okay. And for that, we discuss some of the causes which may lead to the condition in which now you are unable to control the condition, and now you are heading towards amputation, removal of that part. Okay. And the reason may be some whatever the reason is. Usually it is the ischemia, infection, and now you have to you don't have any other option and you are heading towards amputation. So some of the concerns will be related to optimization of the conditions which are leading to this ischemia. It may be diabetes, it may be any vascular disease, part of vascular disease, and now before attempting the amputation, you are trying to give a chance. This will be a surgical decision, but the thing options will you have that you will try to debride the dead area and just try to give a chance. And if it fails, then they need to amputate the part. Okay, when they are doing the amputation, there are certain things which you should be considering will be in addition to the standard one, standard two monitoring. You might need intraarterial blood pressure monitoring and CBP monitoring, because you might need, if the cause is infectious, you might need to give some vasopressor. So for that, you need CBP as well. Or you should be considering that when they are removing the part, especially if it is high amputation, there may be relative hypovolemia. So you have to give, you have to be ready for it, and you might need to give blood and blood products. Okay. And we actually, unfortunately, maybe some part of it we did not record. So I just try to recap. And now we are just focusing on the individual problems which may be there, because this patient might be diabetic. So we just talked about how to control the blood sugar. So there are different options. We can give IV, we can give subcutaneous, we can give IV bolus, we can give IV infusion. Okay, so we had discussed up till now this thing. So now I just said that the better option is to give IV infusion rather than subcutaneous, because subcutaneous route will, the absorption will may be unreliable. Okay. In historically, there are certain regimes, Alberti regime, GIK regime. I don't know. There are so many things, but your concept is that you will be checking the blood. If the blood sugar is high, that you are checking blood sugar half hourly to 1 hourly. This is one thing. Rule number one. Rule number two: you can use any regime. There is a pre-mixed solution with electrolytes, dextrose, and insulin, and there is a rate written on it. Okay, and you can label this as variable rate infusion. You can gradually check the blood sugar, and you can alter the rate accordingly. Okay, this is one of the option. Or other option is that you prepare any insulin infusion, and you do use sliding scale, like maybe blood sugar in milligram per dl divided by 150, and that units per hour. Okay, that for example, if the blood sugar is 450, as I told you, so you divide it by 150, so it will be 3 units per hour. So you will start the infusion as 3 units per hour. Okay, and then you will repeat the blood sugar, and you will titrate the insulin accordingly. So this is one of the factors. Whenever you are giving insulin, which things you should be watching now. What should be your consideration? What you should be doing? You should be doing serial blood gas to see the blood sugar and also electrolytes. Because whenever you are giving insulin, there may be chances of hypokalemia. Okay. But in this scenario, you should be looking at the urine output as well. because you have to keep in consideration the urine output. Okay, only then you will be targeting uh, replacement. Okay, so this is one of the component which you will be facing in. The other one will be related to sepsis. So you have to follow the sepsis guideline. We are not discussing sepsis in detail. We will discuss it separately. But usually, one thing is that by any way you are targeting, you are thinking that this patient is septic. There are some septic markers. There are different laws and different scoring system, Q SOFA, and there are so many SIRS criteria or some. So whatever, it will be some change in the physiological state. There will be tachycardia, lactate will be high. So what you will be doing, that you will be taking the blood, sending the blood cultures, doing the lactate level, and start empirical antibiotic therapy and give a fluid bolus. That's what you do. 20 to 30 ml per kg, and you will see the fluid responsiveness, and you can just set some goals, and then you will be giving more fluid accordingly. Okay, then you will add vasopressor. So what vasopressor would you be using? Norepinephrine. In the sepsis, if you are suspecting sepsis, you will be starting it with the norepinephrine. Okay, you can start in a low dose, like 0.0 0.01 microgram per kg per minute, and then you can titrate according to the response. Then you have to maintain the mixed venous oxygen saturation. Ideally, mixed venous oxygen saturation is through pulmonary artery catheter, which we usually don't use. So you can follow the jugular venous, and you will be targeting around 70, 70%. Okay. So then what else you will be doing? You will be following the lactate levels. You will be doing the lactate levels, and you will be trying to improve the perfusion. Okay, you will be looking at the ABGs. You will be looking at the, if patient is needing some other interventions, you will be targeting that one as well, in addition to what you are bringing the patient for. Because we started with the scenario of amputation in a septic patient. Okay, but usually this patient is having a combo, like this patient will have diabetes, and because of diabetes there is CRF, so patient might be on dialysis. Okay, so you will have concerns related to dialysis. You will have the concerns related to the fistula. You have to take care of the fistula. You have to take care, the patient will be anemic. You will have low threshold, patient will be having anemia. Okay, and so concerns it will be like accordingly. Okay, so sepsis, antibiotic, fluid, lactate, you will be targeting that one. Okay, among the fluid, you can choose normal saline, or in different scenario you can use ringer lactate. You will be monitoring the blood sugar, if, and as we just discussed, that you will be controlling the blood sugar separately. Okay, what else? And there are some other component which will be there isolated, like role of steroid. If the patient is not responding to fluids, patient is not responding to vasopressors, then you will be adding some hydrocortisone. Okay, you will be because this will be part of it. Post-operative care will also be part of it. This patient will be at risk of any septic patient. You have to take care of the risk for thromboembolism. Okay, and if the patient is kept intubated, there will be VAP care bundles, and these things should be in your mind while you are managing such case. Okay, so anything else? Choice of vasopressor. If you want to, in one condition, if there, like, you have a heart failures in addition to that, then you might need to add some inotrope. So inotrope may be dobutamine, or inotrope may be epinephrine. You can add epinephrine. Okay, so anything else, please just add on, please. Anyone wants to add something? Yes, Usman, I just saw you. Abu Bakr, Anila. Anyone wants to say something? Dr. Humaira?
Sir, regional and sepsis, regional
Yes,
anesthesia.
yes, 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 yes. I just slipped out of my mind. So how will you choose between spinal, like for example, if there is knee amputation, would you like to give spinal? What will be the considerations? If spinal or epidural, if you want to give. Actually, the concerns will be related to the coagulopathy, use of anticoagulants. This is one thing. The other thing is that there is high risk of development of epidural hematoma, or epidural abscess if the patient is septic. So it's an individualized decision. Like there are something, and this patient might be hypovolemic and might be having septic shock. So in that scenario, it will not be advisable to give spinal or epidural. Okay. And in some conditions, you can give a regional peripheral nerve block. Like if you want to do below knee amputation, you can give combined femoral and sciatic nerve block. Okay. Or it can be done in that scenario, but there will be considerations related to, because in the septic area, local will not work. Okay. But if the area above it, then there maybe they are using the tourniquet. So there will be, you have to cover that area as well. Even if you have, you are doing below knee amputation, which you can do by mainly by sciatic nerve block, some of the component of saphenous nerve block you can do by adductor canal block, but the area of the tourniquet, for that area you need to block the other branches of femoral nerve as well, including lateral femoral cutaneous nerve, which is covering the lateral part of the thigh. So you have to consider that thing as well. Okay. So these are the things related to uh, regional anesthesia. Anything else, please? Actually, this topic is open ended. Okay, you can have, if you have a crush injury, and crush injury is the source of gangrene, and so you should be thinking about rhabdomyolysis and renal failure, myoglobinemia, hyperkalemia. Okay. And there may be electrocution leading to this condition, and you have to treat the pain, acute pain nicely, because this patient will be a candidate of development of phantom limb pain. Okay. So this is a very challenging case. And by the way, the question, Abu Bakr, what will be, for example, if you have a patient diabetic, hypertensive, and patient is now presented for amputation, what will be the ASA status? If, of course, it will be uncontrolled. So what will be the ASA status? Yes, Abu Bakr.
Uh, ASA4E emergency. ASA4E, I guess.
ASA4, you are right, but in certain condition, it will be ASA3E. It may be ASA3E. Okay. Of
Okay.
course, if the patient is having
So
some
3E, I think would be a good answer. 3E.
3E, or it can be 4E in certain condition. Okay. Like any
Yes, in certain condition.
life threatening, like electrolyte imbalance. Okay. Or patient is in septic shock. In that scenario, it can be 4E. Or patient is having multiple inotropes going on, vasopressors going on, then you can say it 4E. Okay. Try to, I discussed this topic a number of times. You should be thinking about fluid, analgesia, INCN, ASA status, okay, pulmonary risk factors, cardiac risk factors, renal risk factors for post-operative nausea, vomiting, aspiration risk factors, positioning related concerns, airway management plan, induction plan, whether you are using inhalational induction or IV induction, which muscle relaxant you want to use for induction, for intubation and maintenance. Okay. Would you like to give any regional block, any compartment block, any peripheral nerve block, local infiltration? Okay. Use of multimodal analgesia. You should be considering yes, how much is the blood volume how much is the allowable blood loss, uh, anything, any case you are doing. Maybe I'm missing some of the things, like surgical risk, thrombosis risk, bleeding risk, need for patient to for HDU or ICU. Okay. By the way, you know about difference between HDU and ICU? Who will tell? Abu Bakr, do you know what is difference between HDU and ICU?
In HD, we don't have ventilatory support for the patient, mechanical ventilatory support.
This is one answer. This is one answer. There is one more component, that if you have one organ support, it will go to HDU. Yes, Arsalan?
Sir, the same thing I want to tell you. If we have to support more than one system, then we shift the patient to ICU.
Yes.
And when we have to support only one system of
One
the
organ
body,
system other than mechanical ventilation. Mechanical ventilation cannot be done in HDU. Okay.
Yes, sir. I was about to tell you that if the cardiovascular system is involved, then you will straight away shift the patient into ICU.
No, not cardiovascular system.
Cardiac and respiratory system. If the patient is having cardiac failure or respiratory failure, then we'll shift to the ICU.
Mechanical ventilation, I have heard. You're right. But if you have more than one system, or if you need mechanical ventilation, that will be ICU. If it is only one organ system, like for example, a patient is on inotropes, the patient can be in HDU. Okay. But if patient is on vasopressors or inotropes, and now the patient is also having dialysis, now this patient should be going to ICU. This is the difference. Okay. So similarly, there can be aim in day surgery. There may be a patient which can be going to the ward. Okay. What will be the extubation criteria? What will be the what will be the possible complications at the time of induction, maintenance, recovery, extubation, and post-op period. Okay. So if you just tune your mind for these headings and you just try to fill whatever case you are doing, I guarantee you, after doing practice for 15 to 20 cases, I guarantee you the anesthesia will become very easy for you. Okay. Because rest of the things will be related to disease. For disease, what you need to learn, you need to learn is what is the main pathology, what is the main problem occurring in that disease. This is thing number one. Number two, what is its effect on various body systems? And then you will just try to pick out what are the problems related to the system of your interest, like airway. You have to poke the needles, so you should be thinking about anything related to the regional anesthesia. You have to maintain the airway, so anything related to airway, this will be your first priority. And because all of your medications will be affecting the cardiovascular system, so if the patient, the disease which you are dealing is already affecting this cardiac system, that will, your anesthesia will exaggerate it. So you will be planning accordingly. Okay. So just try to read methodical and try to read topic oriented rather than book oriented. Because if you will follow a book, you will find very difficult in practical aspects as well as in the exam, because the exam will not come in there will be a someone will be telling you a question is coming from the page number 952 of bloody Manhus Morgan Sharif. Okay. You will not be able to understand that question, because that will be out of domain of one line or one page of one specific book. Okay. So just try to think logically, try to make yourself in a way that you are able to answer the scenarios in a nice way. Okay. So this was a topic. Any question you want to ask? In a similar way, because unfortunately we missed some of the part of earlier part of recording. So I'm repeating some of the things, that some of the procedures which you can precede the actual occurrence of the level of amputation, there may be need of some embolectomy. Okay. So before we finish, I will ask a scenario to Usman, that there is a patient who had MI 1 week ago, okay? And now that patient is presented with limb ischemic pain and the surgeon want to do embolectomy, okay? So what will be the concerns? How will you manage? Usman is here or left? Okay, anyone else, please? I repeat the question. There is a patient who had MI 1 week ago, and now that patient is presented with ischemic pain, acute limb ischemia, and the surgeon want to do embolectomy. What are the concerns? Tayyab, would you like to say something?
Sorry, sir.
I will just summarize it. Actually, this patient is in active cardiac condition. There is acute MI. Okay, acute MI is up to 1 week. So this patient is high risk for reinfarction. This patient is high risk for cardiovascular morbidity and mortality. This is one thing. Number two, this patient will have therapeutic anticoagulation, or and patient will be on dual antiplatelet therapy. This is number two. Then patient may be vitally unstable post MI. Patient might having some arrhythmia or things like that. There may be residual heart failure because of the MI. So these things will be related to that. So it's a high risk condition. There are high chances of perioperative morbidity and mortality. This is one thing. Then now the other side is that you cannot delay embolectomy because it will end up in having ischemia, and then you will have the same patient for amputation. Okay, so you have to avoid that thing. So number one, you cannot delay it. You have to proceed with it. Number one. Number two, you will be optimizing the risk factor. So in this scenario, because that patient will be on in the therapeutic anticoagulation and dual antiplatelet therapy, so it will not be possible to give any block or any like regional anesthesia will be almost out. It will not be safe to proceed. The thing is that you will be discussing with the surgeon, and usually these days these procedures are being done endovascular. Okay, so what you will be doing, that you will be arranging the, of course this patient should be in ICU or HDU. Okay, and this patient will have high like you will be doing the invasive monitoring. In addition to standard 1 and standard 2 monitoring, you will be doing intra-arterial blood pressure monitoring. Should have maybe you will be needing a vasopressor or inotrope, so you should have CVP, and you will have high risk consent. Okay, and then you should be ready for any unwanted event, and they will be using local, and this will be procedure will be done as endovascular embolectomy. Okay, so you will be maintaining the myocardial oxygen demand supply ratio. Myocardial oxygen demand supply ratio, because whatever stress you are giving, it will be increasing the requirement and decreasing the supply. So you will be targeting at controlling in heart rate. You will be targeting in avoiding avoidance of the stress response. You might need to give some anxiolytic, and you can do this procedure with local and conscious sedation. Okay, and of course you have to outweigh the risk of aspiration, and airway management will be accordingly. If you need to give general anesthesia, you can use LMA if there is no risk of aspiration, because that will be less risk, and you can use opioid based anesthesia or use of etomidate if the patient is unstable, things like that. Okay, so I think we will stop here. Any questions, please? Do you like the scenario? This is a scenario which is being done in almost by every one of us in emergency. Okay. So any question before we finish? Okay.
Is there any
Yes,
point
Abdul.
where we will be considering collards too? Because we usually don't use them. can we consider colloids too in septic patients for
Why you don't
resuscitation?
use colloids? Why you don't use colloids?
Because already most of our patients have coagulopathy, and we don't take the risk of
Okay.
adding.
Okay, Abu Bakr, I will just add on to you because there are different types of colloids. Okay. So if you don't have albumin and you have dextrans or you have hesteril, maybe yes, you can say that there are some more complications. But if you have albumin, albumin is safe to use. There is less chances of unwanted problems. Okay. So you can use as a bridging in the time. If you, for example, if there is indication for blood transfusion, you will be transfusing the blood or blood products. If there is any coagulopathy, you will be. But remember one thing, that is especially in such scenarios, you have to outweigh the risk versus benefit. This should be your answer. And actually we do like that. In case when you have to increase the blood volume, like you have to maintain the circulatory volume, you have to give colloids. Because if you have a patient with limited cardiac reserve in which you don't want to give over fluids, so you can give colloids. Okay. I hope you are clear now, Abu Bakr.
Yes, sir.
Sir,
Yes.
can we improve the cardiac function? Like patients are having low ejection fraction and diastolic dysfunction
So what will you do?
in emergency.
What will you do? What will you do in that scenario? You have to use either low dose epinephrine, or you have to use dobutamine, or if it is right heart failure, you can use milrinone. It will be depending on the scenario. Okay. Milrinone will be causing vasodilatation. Dobutamine also cause vasodilatation and tachycardia. Dobutamine causes a lot of tachycardia because it's a beta receptor agonist. Milrinone is good for right heart failure. And if you are combining it with norepinephrine, you can counteract the effect of vasodilatation. Okay. So there is no fixed rule or recipe. You have to modify according to the scenario and according to the situation. Okay. As the sepsis protocol says, that you start with one. If you have a septic shock, you will be starting with norepinephrine, and then you will be looking at the parameters. You will be doing the ABGs. You will be looking at the lactate, mixed venous oxygen saturation. If you have pulmonary artery catheter, you will be targeting the and you are calculating the cardiac output. Then you are using cardiac output monitor. You will be looking at the SVR. You are following that parameters, and then you are acting accordingly. Okay.
Yes, sir. Thank you.
Okay. Thanks a lot for your presence, and we will do some next topic next time. And I think Abu Bakr, you will be able to find the topics now easily. All of you
Yes,
are
sir.
welcome.
Inshallah.
Whenever you face any problem in finding any topic or anything, you are most welcome. Okay. Thank you.